thank you, Samuele Cortese, for joining us at ESCAP today to talk about your presentation that you will give on our online event in June. Can you just give us a little bit of an overview of what you will be presenting to us?
Sure, thanks. So I plan actually to divide my talk into two parts. So in the first one, I will basically provide an overview of the most recent evidence base for the treatment of ADHD from randomized controlled trials, but also from other type of studies, in particular observational studies. And I will focus both on the pharmacologic and the non-pharmacologic treatment. In the second part, I will highlight really what are the gaps that we need really to understand better in the future in terms of translating the evidence from research into daily clinical practice. Because I guess that it is fair to state that we have advanced quite significantly in the past years in terms of understanding how current treatment works and what they do in terms of changing the outcomes in patients with ADHD in the short and possibly in the long term. But we really need to have more research, more evidence to translate this into the daily clinical practice, because there is still a gap there. And this is quite evident when we interact with colleagues who are researchers or clinicians. We always feel a kind of tension between these two words, and it should not be there, because really research and clinical aspect, they should be strictly connected.
Trials that are looking at perhaps some new drugs in the pipeline that may perhaps complement or even replace the current treatment strategies that you use for ADHD?
Sure. So I usually say that the field of pharmacology of ADHD, clinical pharmacology, is a tricky one for those who want to enter in this field and come up with new compounds, with new molecules, because we do have compounds which are highly efficacious, at least in the short term, as we can see from randomized controlled trials. So if we look at the effect size of stimulants, amphetamines, but also methylphenidate, they are actually the highest effect size that are available across all the medications used in psychiatry, and among the highest across the entire field of medicine, at least in the short term. So clearly any new compound will have a quite difficult time in terms of comparison to this. However, of course, there is room for additional compounds, and there are studies in the pipeline in novel compounds because of a number of reasons. So first, not everyone responds to stimulants. Roughly, percentages varies across studies, but roughly around 70% may have benefit from one or the second stimulant, but roughly 30% do not benefit or do not benefit enough. Second, of course, some patients may have beneficial effect, but they can't tolerate side effects. Even if in general, it is possible to manage the side effects of stimulants without stopping them, for some patients, clearly this is not the case. So, of course, we need alternative classes. There are also other reasons that have to do with the duration of action and also the effect of this medication on outcomes that go beyond the standard, the classic outcomes that the majority of randomized controlled trials have measured, which are the so-called core symptoms of ADHD, so inattention, hyperactivity, impulsivity. So definitely, I would say, to summarize, that we have a good medication for ADHD, but definitely there is a need for additional compounds. And looking at the recent years, there have been a number of trials on additional compounds. Actually, I think we can group these trials into two different types. So the first is actually stimulants, but different ways of being delivered to meet important need in daily practical life. For instance, formulation that cover the initial hours in the morning or late in the evening, so to cover all day, and formulations that are also more practical, such as patches or liquid formulation. The other group is about compounds which are not stimulants. So far in general, we have not seen groundbreaking findings from these trials in terms of molecules with spectacular effect size, which are better tolerated than stimulants, but definitely they have contributed to bring more molecules to the armamentarium. And so it is really important because we don't have any predictor of response to medication. So it's important to have a number of different options.
What age can you start medication on for children?
It is commonly accepted and also established recommended in a number of guidelines that the pharmacological treatment is appropriate starting from the age of 6, 7, so the primary school age. The controversy is really around the use of these medications in the preschoolers. And of course, preschoolers is quite a vague term because it changes across countries, but roughly speaking, I'm referring to children younger than 6 or 5 years. So in this case, the majority of guidelines do highlight the fact that the evidence suggests that these medications tend to be less efficacious and in particular less well tolerated compared to when used in school-age children. Okay. So there is a note of caution, and of course clinicians can and should, when needed, use this medication in preschoolers, the age of 4, 5, but we need to pay attention and to use quite low doses and to monitor carefully side effects after, of course, using non-pharmacological strategies. And there are currently ongoing, especially in the United States, a series of studies in preschoolers. So hopefully we will have more evidence base in the future, because if we look right now, actually, the number of trials for clear reasons is less than the number of trials we have for school-age children, clearly.
I've seen some of your studies that you look at 4 weeks and then 7 weeks. What are the longer term lengths that you use for prescribing drugs?
This is an example of what I was referring earlier on as a kind of gap between the evidence and what happens in clinical practice. So if we look, first of all, of course, when it comes to assessing the efficacy of a treatment, we all are familiar with the notion that the randomized control trial is the best design because it reduces the number of bias. So if we look at the average duration of randomized control trials out there for stimulants and other non-stimulants for ADHD, it is around 12 weeks. So we are talking about a few months. There are very few longer randomized control trials, and there are different reasons for this. Ethical reasons. It's not ethical to randomize somebody to placebo for long term when there is a good response in the short term, and practical and economic reasons, financial reasons. However, in the clinical practice, we tend to treat them much longer than a few weeks. So we do have also some other type of studies that are informative, and these are called withdrawal randomized trials. So individuals who have been taking this medication for years, they are randomized to continue the medication or go to placebo. In this case, we can assess if there is a maintenance of effect. And there are some withdrawal randomized trials out there in the field of ADHD medication, and they show a persistence of effect, even though the size of the effect seems to be lower over time. But it's not clear yet if this is due to a kind of development of tolerance, the medication are less effective over time, or this has more to do with the way the study was designed and the dose and how the medication was optimized. So if we look at the evidence base, we can say we are quite certain that in the short term they work. In the long term, evidence base is still not very clear. What do we do in clinical practice is that, of course, we tend to treat them longer, but usually it is recommended to stop at least once per year the medication to have a break, to assess if the medication is still working or not. And so the answer, commonly this is a common question when we start medication from patients and parents: how long does my child need to take this medication? The answer is as long as they need it.
Yeah.
And we don't know at the beginning, because the trajectory of ADHD over time is different across individuals. In some it stays quite impairing, for others things go better.
And that's where you started off by responding and saying about how important it is for guidelines as well, and how clinicians need certain guidelines, especially if they're going to medicate patients. So that brings me to your involvement in the European ADHD guidelines group. And I was wondering, obviously we're coming from ESCAP, we try to represent the whole of Europe. So in terms of the demographic differences in prevalence and diagnostic tools and treatment options, how do you sit down with your team, your group at the ADHD, and try to generate certain guidelines for aspects of ADHD when it can vary so much between country?
So this is an interesting question. So as you say, I'm part of the European ADHD Guidelines Group, which is a working group of a larger network, which is called UNITAI, this European Network for Hyperkinetic Disorders. So we are a group of around 20 people. We do this in our spare time. Basically, we are not paid to do this. And our remit is really to review the evidence, and also, and based on the evidence and our expertise, to write, to produce, rather than guidelines. Actually, I would say more guidance, because the process of producing guidelines is a very complex one. It includes, including a stakeholder, doing analysis of cost effectiveness. So it's a very complex process that, for instance, NICE in the UK does in a very rigorous way. So our mission in a way is different, slightly different. We don't want, actually the name AAGG may be misleading. We are not a group of guidelines. We provide guidance, a recommendation for aspects that are not really covered in general guidelines.
Yeah, okay.
So for instance, some years ago, we published a paper on the management of side effects of ADHD medication, or another paper more recently on the use of parent training. So these are a kind of niche topics that are really important, but they are not covered enough in standard guidelines. So this is really what we do. You are right in saying that, of course, there is a difference across countries in the UK in terms of practice. But I would say that actually there are also similarities. Mm-hmm. For instance, we tend to think that the prevalence of ADHD is very different across European countries, for instance. This is true if we consider the administrative, the administrative prevalence of the disorder versus the real prevalence. What do I mean? So if we use the same diagnostic tools, with the same method to diagnose ADHD, there are studies showing that there are really no significant differences across countries. But if we look at the administrative prevalence, so really how, to which extent a disorder is really diagnosed, then there is where we find significant differences across countries, meaning that in some countries, practitioners are more familiar with the concept of ADHD, have received proper training. In other countries, they're less familiar and they have not been trained properly. So I think that our guidance addresses this general aspect that are really valid across countries. But then the purpose, of course, the goal is to provide a kind of general guidance that then will need to be adapted in each country. And we represent a number of countries in Europe, so we are confident that this may be the case in national guidelines or guidance. So we know that some of our papers have been quite influential for national guidelines or recommendations.
Thank you very much for speaking to ESCAP, and we look forward to your presentation in June.